Hello and welcome to everyone. I believe there's probably still a few people that's gonna join us after a while, but it's my honor to introduce you to today's topic that we're going to discuss in the hematology deep dive. You all be wondering what a pediatrician is doing here, but obviously, luckily, we're talking about something called hemophilia, and it's something that you get inherited. And so that's why both me and Dr. Goga is from the pediatric side. People always laugh to me if I talk about the adults or the groot mense that is managing the other patients. So, but I think today Dr. Goga is going to touch on a very important topic for us. It goes about the safety and efficacy of aPCC for the management of bleeding and surgery in hemophilia patients. Um, yeah, I think that's a very important topic. And then we would like to thank Takeda. They sponsored today's session for us. Um, Herdrin, can you move the slides? Seems like. Mhm.
Yes, sure, sorry.
No, it didn't want to. It did now, no. Okay, so together with Blood SA, Takeda has sponsored this deep dive for us, and this is being done in the strategic partnership with the South African Clinical Hematology Society and SASITS that we're gonna, okay. So and for all of you that don't know the team, but I guess everybody is well known with the deep dive management team. We've got Professor Verburg, who is the leader, then Khadin, who has organized everybody. And it's like, okay, here I am. And Khadin, she has ways to find you whenever you think you are just hiding here in the middle of the country, keeping yourself out of or yeah, out of all the dangers in quiet and peace. So she's the national training coordinator. And then we've got Dr. Nicole Smith, who is the national outreach officer for the deep dive management team. Just some housekeeping notes. All recordings will be recorded and that it can be found on the website afterwards under resources and deep dive. Um, Everybody must please feel free to interact and add questions into the chat box. So we will keep an eye on that, and that answers will be answered at the end of the session and on the end of the presentation. But please keep on adding questions. Um, Regarding the CPD points, um, you have to attend for at least a whole hour. And you must make sure that your MP number is entered correctly when you sign up for the deep dive. And the deep dive points will be automatically submitted um, to the HBCSA as well. And so these are the things, yeah, and when you registered, you must make sure that you are have entered on and is attending on your own Zoom link as well. So otherwise, we won't know that you were also there, even though there's a photo or whatever. But that's how they count the numbers for us as well. So, and so when you sign up, but for any questions or queries that you've got regarding the CPD attendance certificate, for another country, please email this to the admin@bloodsa.co.za. Okay. Then you can join our mailing list via our website, where you go to the resources section and subscribe to the deep dive, or use the QR code that is being displayed on the screen here as well. Then you're very welcome to give feedback. Blood SA and the speakers value your honest feedback. And please complete this anonymously. Um, the feedback survey at the end of the Zoom meeting. And this is the only way that we can improve future sessions. Or remember that all of us can read and find few and little obscure facts that makes you remember stuff easier. And it's rather welcome to teach this to the rest of us about that. One of our honorary professors on this side said, um, life is too short to learn from your own mistakes. You've got to learn from your predecessors' mistakes. And the people that follow you is going to learn from your mistakes in the end as well. So today's agenda is obviously there's the topic is going to be presented to us by my esteemed colleague, Dr. Yasmin Goga. This will be followed by a questions and answer section and then the closing. Okay, so I have known Dr. Goga for many, many, many years. When we both started, she was at Albert and Corsi training as a pediatric hematologist, and I was training as a pediatric oncologist. Um, but Yasmin is definitely one of those people that always stands out of a crowd. Whenever she speaks, she demands attention, and she does it in with her kind spoken, kind-hearted, just such an amazing, genuine way. Yeah, Jasmine, I have admired you all over these years. I still remember, I don't know if you remember the one Massac where you pitched with this massive coffin of a suitcase, and if all of us were the small ones, and then the next year you had the small one and all of us had bigger ones. So I don't know who was the right person, but anyway, so I remember that was a small little fun fact that but I always thought that, okay, men and ladies definitely need different things that you can add on to. Dr. Goga is an expert in the field of hemophilia, and she's definitely one of the people that I and my fellow colleagues turn to seek advice about hematology patients. And I'm looking really forward to listening to this talk. And I think with that, we are off to you, Yasmin. Have a lovely afternoon, everybody.
Hi, good afternoon, everybody. I'm actually feeling very uncomfortable now with all of that from Jan. Suffice to say, it's been a pleasure knowing everybody. And about me standing out in a crowd, well, I try to make myself invisible sometimes. Anyway, let's get on to what we need to get through for today. So, my task for today was to discuss the safety and efficacy of aPCC, particularly in the management of bleeding and surgery in hemophilia patients. So just the regular disclaimers and conflict of interest. I have received some speaker fees for this presentation, and I do not think at this point I have any significant conflicts of interest. So the question in terms of the agenda for today is, why all the fuss about surgery in hemophilia? Because it's pretty unique and it can be pretty stress-inducing. And it's a necessary activity from time to time. Even though we might dread it, there are many cases where we need to go to surgery to improve our patient's quality of life. What we've never really, I think, spent much time considering is the definitions of major and minor surgery. We're all familiar in different ways, different units run things differently with principles and planning. What we will do is look at non-inhibitor surgery, and then we'll take a look at the inhibitors and surgery in that particular group. And then we've also got, thanks to people like Jan, several patients on emicizumab and some of the newer agents hopefully coming through in the next few years in South Africa. And how do we manage patients with inhibitors who perhaps will be on drugs like emicizumab and going to theater? So the question really is, why is it so different? And the bottom line is that if you don't have optimal cover in a patient with hemophilia, you have a 10 to 20 times higher bleed risk. That bleed risk is not just I'm going to bleed, it's a question of where you're going to bleed and what's going to be damaged in that time period. So we are all painfully aware that factor replacement is costly. Depending on what your postal code is, it can also be logistically a nightmare. And then when you add a second layer on that, so you've got a patient with hemophilia, now you need surgery, and then you want to do, you have a patient with inhibitors, your choices become fewer in terms of what you can do and how you monitor. So if, for example, you are one of my colleagues in Mthatha, where your inhibitor screens and titers are flown up to Johannesburg, you can imagine the challenges of trying to manage a very complicated inhibitor patient. And because of this, it means that surgery is often delayed or denied in certain parts of our country. This is undoubtedly very high stakes. Errors do lead to catastrophic outcomes. And I can't think of another place where it is so essential for this team to come together and work well to plan from beginning to end what needs to be done. Now, I must turn to my surgical colleagues for a moment and not forget the other half, the anesthetists. This is a rare disease. Unless you are in a higher volume unit, it is unlikely that your orthopedic surgeon or your neurosurgeon would have come across many cases requiring surgery. And the same goes for anesthetists, right? I think one of the other important things is the bleeding risk is not necessarily proportional to the tissue trauma. You need to take into account where is the site of your surgery. And the take home from this is your timing and your logistics are as critical as the incision itself. So many of us have included this in our presentations ad nauseum, but nowhere is this contrast more stark sometimes than in hemophilia and surgery particularly. So if you look at the global context, in high-income countries, you've got a lot of structure. These kinds of operations are done in high-volume units, right? They have different medications available. So you're dealing with patients who, especially if they have inhibitors, mostly would be on emicizumab. Many of them have access to extended half-life products. So we have not seen those patients, but we need to manage the patients we have. And unfortunately, the longer you delay things, especially surgery, the more difficult sometimes this can be. We know we live, and it's getting worse, that our access to factor is increasingly restricted. And when you are trying to do difficult things with less, you can imagine that the stakes are much higher. So in South Africa, it's not all doom and gloom. You do have some centers, which are tertiary centers, which are doing phenomenal work. I've just looked at some of the abstracts submitted for MASAC, and I'm astounded at the number of joint replacements, for example, that have been done. But that is definitely not the case in every province. And I think those provinces who are able to do that kind of surgery stand out alone and separate. So we have equity gaps across provinces, and we have equity gaps, yes, between private and public, and even within the private sector. Many of you would know that we are still continuing to develop our registry, and surgery and the capture of our experience with surgery also needs to be included in this. The updated guidelines for hemophilia should be released soon. I'm hoping in the next 2 to 3 weeks. But the reality is, at this point, we have no national surgical protocols for patients with hemophilia. And this is something that MASAC has identified, and we need to work in a targeted manner, probably starting with circumcision first. So our go-to as treaters remains the WFH 2020 guideline. And I must say, from all the guidelines that I've had to interact with, this is one of my favorites. I really love the way it's done. I love the comprehensiveness of it, the fact that it caters to resource-rich and, dare I say, resource-poor countries. But you've also got some nice video clips. You've got some summarized PowerPoint presentations. So there's a lot of material here that is presented in a very easy to read manner. For specific hemostasis guidelines in surgery, there is an additional guideline which is done by the ISTH. And this is where I want to pause a moment, because when we think of how we treat a patient with hemophilia who's going into theater, we have to ask ourselves, what are we planning for? Is this something major or is this something minor? And it's not as simple as that, because we know that the devil is in the detail. But just as the first step, major or minor surgery. So WFH uses a definition where they say that if you require hemostatic support for more than 5 days, then that is regarded as a major bleed. Okay. So we're going to look at major and minor surgery and try and unpack some of those definitions. In preparing for this talk, I looked at the literature and just looking across the spectrum, general surgery, composite studies or reviews, and then neurosurgery, cardiac, circumcisions in particular, and then orthopedic surgery. So Solomano in 2017 published at that point what was the largest review of surgery in hemophilia, having screened almost 1,000 publications. Just 340 were included, and of those studies, only 95 categorized surgery according to whether it was major or minor. So if we stop and we think about, if we are looking to see how do we manage an orthopedic, a total knee replacement, what is the quality of literature there? What definitions are they using? And are we all speaking the same language? So that's the first question. Out of almost these 1,000 publications, only 7 provided definitions. And that's our first stumbling block. So as part of this, they looked at the level of surgical invasiveness and tried to use that to define what is major surgery. So one of the requirements was that you would require a general or spinal anesthetics. You required respiratory assistance. And then if you had surgery involving the abdomen, penetration of a major body cavity, orthopedic surgery, in particular joints, and interestingly enough, the extraction of more than 3 teeth. So dental care in this country is horrendous, especially in the public sector. And this is a scenario that we are facing more and more as we go along. So from trying to understand what is major surgery, this is the definition that they came up with. Any procedure with a high bleeding risk, or if it required prolonged hemostatic coverage. So examples of this would be a laparotomy, a joint replacement. And by long hemostatic coverage, what they meant was 7 to 14 days. So there's this line between 5 days, 7 days, and it's not still quite clear. These should be planned in tertiary centers with hemophilia expertise, and the MDT management is crucial. So if we switch and look at what is minor surgery, so by default, it should be where you have lower bleed risk or requiring shorter periods of hemostatic cover. Examples here would be dental extraction, so less than 3 teeth, circumcision, interestingly, as well as endoscopy. So typically here, cover is required only for 1 to 3 days. And whether you use factor or bypassing therapy, it's often a single dose or a short course. But in this kind of surgery, adjuncts like tranexamic acid or local hemostatics are actually critical. And this, although it sounds minor, it is not to be dismissed. It still requires planning and very clear protocols. So the question really is, why distinguish major and minor? And this was found in some kind of electrical apprentice handbook. Using slang words and terms can result in the wrong requirement being applied to an installation. Okay, we're human beings. We cannot end up with wrong installations. So we need to be very clear. What is the type of surgery? How long is this patient going to require a factor for or bypassing agents? And what sort of planning will we need? It also creates significant impact, especially if you're doing major surgery and things like joint replacements. Those units, be they the orthopedic units or the hematology units, there's always this pushback from orthos to say, no, the heme budget needs to cover your factor. Wherever the money comes from, we need to have an idea of how much it's going to cost, how best to do it, and we need to sit at a table and discuss this, right? So you can see from the Solomino studies that there's very little of the same language being spoken, and it is hard then to compare the various case reports and case series that have been published. So where are we at the moment? According to the WFH, World Federation for Hemophilia, they regard it as major surgery if cover is required for more than 5 to 7 days, or if this is a high-risk site, right? ISTH, however, says it's major if it's more than 2 doses of factor or more than 3 days of hospitalization. As South Africa, we need to decide where we are going to. And for now, we've aligned ourselves with the WFH guidelines. But I think regardless of whether we decide WFH or ISTH, all units need to code the same way. That's the important thing. So why do definitions matter? Because as I said, it determines your perioperative hemostatic strategy. It has a huge impact in terms of cost and outcomes and getting the go-ahead, getting the buy-in from finance, from your CEO when you're going to look for larger volumes of bypassing agents, for example. It's really important for us to be able to benchmark across centers. And it's essential when we're doing things like the registry to have very clear definitions so we can actually start to look at gathering data and assessing outcomes. So this group is no stranger to PBM. And sometimes I feel like we beat on really silent drums. We interact with surgeons on a regular basis. And if you look at most tertiary hospitals or quaternary hospitals, the glaring lack of PBM clinic and workup, it's just astounding. Nowhere is this more vital than in patients with hemophilia. We know you have a bleeding risk. We know your bleeding risk is high. Therefore, you need to be prioritized way in advance in terms of let's plan. How can we optimize your hemostasis? How can we optimize your hemoglobin? So this is a really good article, which was done by Poston and Cruzejaris. It's one of the ASH series. And it's something where I think if you're using it to teach or just to center your unit, it's really done it very well. So preoperatively, what you want to do is confirm your diagnosis. Critically, assure that resources are in place for successful surgery, and don't just think about the surgery. Think about the various what ifs. If all goes well, that's great. We have a factor or bypassing agents left in stock. That's wonderful. If things don't go so well, do we have enough for this patient in the post-operative period? Always consider your comorbidities because these can actually worsen your hemostasis challenges. Have a clear written plan, right? Perioperatively, you need to be clear in terms of if it's major, if it's minor, what are the target levels of factor that you are aiming for? And then we don't have much choice in South Africa at this point. We have a little bit of choice in terms of bypassing agents, but not in terms of the state sector factor derivatives that we are using. Post-operatively, you need to decide how long do you think you're going to be needing cover for. Understand that for certain patients, the risk of inhibitors may become more apparent in the post-operative period. And then you've got this balance, especially in patients who are having cardiac surgery, who are having knee replacements, between the need for thromboprophylaxis and preventing bleeding. So this is really the crux of it. Okay. I wish we all had happy, smiling teams every day. I think if we talk to each other more, if we understood each other, and we actually sat together and did clear plans, much of the frowns, much of the miscommunication can be done away with. But again, this is really important. When you're doing surgery in a patient with hemophilia and in a patient with inhibitors, I think it's vital that your surgeon, your hematologist, your nurse, your anesthetist, and ideally your physio as well, and your pharmacy representative, sit down and understand exactly what we are looking at, how long, how much factor. That's really, really critical. So when we look at target levels, and this is coming from the WFH guidelines, for major surgery for both factor 8 and factor 9 deficiency, our aim, because remember this is major surgery, our aim is to have factor levels sitting at 80 to 100% at incision. So when the patient is on the table, at that point, when the incision is being made, your factor already needs to be in the patient. You need to ideally maintain this at about around 50% or more, depending on what has happened in theater. So if it's been a difficult surgery, if you've got constant oozing, whatever it is, if there's more bleeding, evidence of that through dropping hemoglobins, lots of blood from the drains, etc., then you know your patient is in trouble. You don't have enough hemostasis, and you actually need to go and aim at higher levels. So especially for neurosurgery and for cardiac bypass, this is where you need extended coverage and you need to aim for the higher levels. For minor surgery, you aim for levels sitting at around 40 to 80% and looking at 1 to 3 days of coverage. Like I said, it's not about numbers. So this is not just about trough levels. This is about clinical assessment. Look at your patient, look at the drop in hemoglobin, look at your hematocrit, look at the drainage from the wounds, right? So all of these things need to be done to get a composite picture. So when you look at other options, this looks at 4 scenarios. So hemophilia A without high theta inhibitors, that is fairly simple. In this country, we don't have the option for any extended half-life products. But here, if you do have them, you need to understand what the pharmacokinetics are, because it's very different to your standard half-life. In hemophilia A patients with high theta inhibitors, you've got choices. So you've got aPCC or you've got recombinant factor 7, right? Often you might have a patient who is sitting on emicizumab, and then you need to decide, okay, what sort of surgery, which is the right agent to use? So generally with hemophilia B with inhibitors, it is always advised that one uses ideally a recombinant product. More so if the patient has had allergic reactions, then we are quite uncomfortable with using aPCC. Remember also that when you use aPCC, that you can get an anamnestic response. So when you're looking at it, you are trying to understand what is the cost of your product, how much are you going to need, what is in your pharmacy, what can be obtained, and how familiar are you with both of the agents or the available agents. So intraoperatively, it's really important. And you find this especially amongst tertiary quaternary units where it's usually the anesthetic registrar who comes around, and you end up giving a little mini tutorial on when exactly he needs to give each agent. So Standard half-life factor, this can comfortably be given an hour, 2 hours before the procedure, but especially when you have recombinant 7, for example, that we cannot have a delay. So ideally, you need to give that when the patient is on the table before your incision, right? You also need to make sure that you've got access to your adjuncts, so things like tranexamic acid, some of the tissue glues that you might need. And really, this is not a surgery where it's left to the most junior person. This requires your most senior people on board because you absolutely need to have meticulous hemostasis. Ideally, you want techniques which involve minimal invasion. And again, we discussed this last year at the MASAC meeting. The anesthetist generally will use either a rotum or a TIG, especially in tertiary centers, because that's what's available and gives them a real life picture of what's happening. So post-operatively, it's really not over. Until that patient walks out of the hospital, it is not over, right? You need to maintain your factor, your bypassing cover as per your plan, monitor for bleeding, monitor hemostasis. Because of the increased risk of bleeding, and you definitely don't want to take this patient back for a relook, you're trying to minimize complications, it's important to look at your antibiotic prophylaxis. Generally, for pain control, we would say avoid nonsteroidals. And then the move now is for early physiotherapy and mobilization. Again, through all of this, you're going to have to maintain adequate cover, right? So just a note on patient blood management, and I can see a very clear link in terms of how important it is, not just for a person with hemophilia who's going to surgery, but just in general, because it's part of the same environment that we are working with. Our factor is plasma derived. It all depends on what's coming into blood bank, and it's up to us to use this appropriately. So I think what we can improve on generally is our preoperative management and optimization of patients. So we need to actively screen patients, we need to correct anemia, and we need to do this more aggressively. Because of the way our services are often structured, this, I think, falls through the cracks sometimes. It's not done optimally. And the default is, well, okay, if he needs another unit of blood, so be it. But this can be done better, and it should be done better. We also need to look at autologous blood harvest where feasible. Goes without saying that within the operative field, we need to look at cell salvage. Tranexamic acid is become sort of routine and standard through most of this. And then importantly, as a foundation principle, we need to conserve blood as much as possible. So here you have a high-risk scenario, and you actually need to do it much better for this group of patients. So generally, when we're looking at PBM, we still maintain, even though you are a hemophiliac, if you are not bleeding actively and needing resuscitation, we will still maintain a restrictive transfusion strategy. So hemoglobin of less than 7, local measures I've spoken about already, and then to optimize your coagulation profile. So what's missing is dedicated clinics. What's missing is things like cell salvage. I'm not sure how widely available it is in the country. And then, of course, we need more education all around. So the anesthetists are on board, I think, largely in terms of restrictive transfusions, but the units all need to come up to speed and speak the same language. So we need to embed PBM steps in all our surgical checklists, as well as in our hematology clinic planning checklist, right? And this is not an optional for us in South Africa. Blood is scarce, blood is expensive, so it's actually really essential. So I want to just talk a little bit about tranexamic acid, right? And why it's so important. It's a synthetic glycine analog. It blocks plasminogen binding. But in a nutshell, what it does is that it inhibits fibrinolysis. So it stabilizes the clot at the wound site. It's really very effective when you look at mucosal bleeding, especially dental, ENT, genitourinary, but it is increasingly being used as an adjunct in other surgeries, in particular orthopedic surgery, to reduce drain output and subsequent transfusion. So it is definitely not a replacement for factor or bypassing agents. It is an adjunct. It helps. That's the bottom line, right? So this can be given IV, orally, or topically. Apparently, this is the price in the state sector. I was a bit shocked when I looked at the private sector for a month of oral tranexamic acid. I think at some point it was almost 1,000 Rand. So when you look at tranexamic acid, most of you are familiar with dosing. So we're looking at 15 to 25 milligrams per kg, and that's generally given every 8 hours. For dental and ENT, it's very useful to do it as a topical mouthwash. So a swish and spit. And just be mindful of doses when you have renal impairment. So here you have to be cautious. When you look at it in terms of the context of bypassing agents, it is quite safe to use with recombinant 7. But you need to be careful when you are using it with aPCC, right? So in major surgery, it can be given pre-incision and continued, and you always combine it with factor cover. So when you look at orthopedic surgery, the early complications are hematoma, wound infection. Late complications can be things like joint infection. But intraoperatively, you're looking at blood loss of about 500 to 600 mils, despite cover. So what you need to do is actually optimize your patient and the planning before that, right? There is discussion in terms of whether robotic surgery here is better. And I guess it depends who you speak to. You speak to an older orthopedic surgeon and he's like, this takes a long time to do. I have a better feel of it with my hands. But really that comes down to, again, saying the more you do something, the better you become at it. So if you are used to doing it in a particular way and you have good outcomes with that, then generally you stick with that. So for some of the pearls that we need to check, because when we are in our clinic and we are managing a patient who doesn't have a surgical bleed, it's usually easier. It's within our domain of control in a way. But now you've got multiple members of this team. You've got theater, you've got ICU, you've got the surgeon, you've got the anesthetist. And it's really important that everybody is coordinated. So you need to check that factor is actually available. You need to make sure that if it's not, it's all planned, right? I've spoken about the need for a meeting, and unless it's emergency surgery, don't do it on the weekends. Don't do it in a long weekend. Don't do it on a Friday afternoon. Plan these kinds of surgeries early on in the week so you have enough time where if there's problems, you can get through them. So when you look at neurosurgery, and unfortunately, this is something that we as pediatricians often see. We have patients with massive intracranial bleeds, often presenting as a first presentation. And here, communication is really important. So you want factor levels of 100% pre-incision. You're going to treat these bleeds for and the surgery in that whole period for at least 14 days and often a further 2 weeks sometimes after that. There's absolutely no tolerance for troughs here because the risk of a rebleed and the risk of coning is substantial. Where you can and when you have indicated, then you need to use neuromonitoring, but really no delays, no gaps. And it's critical that the team works together and makes decisions together. So we sit on opposite ends of the spectrum, and I'm happy to say that we have now an increasing number of patients with hemophilia who are into their 60s and hopefully into their 70s soon. But this brings with it further challenges, especially in terms of urological surgery that they may require. So this is a series that was published in 2024. It was a retrospective multi-center series. It focused on hemophilia patients undergoing urology surgery. And they also included both inhibitor and non-inhibitor patients. What they were looking at was trying to understand how much factor was required, what was the bleed risk, and what were the outcomes. Now, look, this was a study done looking at patients across Europe. I'm going to share with you some of the low middle income country experiences, which is very interesting. But this is the latest data set on genital urinary surgery, and what it shows is that it is feasible. We know that these particular areas, prostate, nephrectomies, these are high bleed risk procedures, but it is feasible with cover. Major rebleeds, major uncontrolled bleeding in this group was rare as long as factor replacement was structured. So they did note that in inhibitor patients, there was a higher risk, but they also noted that it was manageable and that tranexamic acid again featured. It was effective in reducing hematuria. So the length of stay expectedly was slightly longer than non-hemophilia cohorts. Factor consumption was proportional. The more complex, the more difficult a procedure is, the more factor you're going to need. But importantly, there was no excess mortality. So for years now, even our simple procedures, like an elective circumcision, we've had a lot of hesitation. We've had a fair amount of pushback. And I think it is driven to some extent by fear. So when you look at summaries like this, you have to ask yourself, are we able to do this? Do we have the skill? Do we have the insight to understand what is required? And I think we absolutely do, right? So the bottom line for this is urology procedures should not be deferred in hemophilia. You sit, you plan what is needed, and you go into it. But we also need to then look at what's going to come through in the future. So our first looming task is really to look at the circumcision protocol, because the drive in this country for circumcision is increasing. But then we need to look at other things, like your TURPs and prostate biopsies. So I'm going to pause here for a moment, because the question really is cardiac surgery in patients with hemophilia. For some of us, it might be heart-stopping. For others, it might just induce a tachycardia. There will be some sleepless nights for those patients. So this was also a multi-center retrospective study done by Lin in 2021, and they reviewed patients with hemophilia who are undergoing cardiac surgery. So these included coronary artery bypass, valve replacements, and the factor replacement strategies varied. Small numbers, but I want us to think about what are we going to face. We definitely have a population of hemophilia patients who are surviving, and they are going to be this group that are going to need either bypass or stents inserted. So this was looking at 30 procedures, and it was the first detailed look at whether cardiac surgery was something that was feasible or not. So the key findings was that this is feasible with structured perioperative cover. The bleeding rates were acceptable, but you have to have high factor targets, understandably. There were no major thrombotic events reported. And then again, the adjunctive use of tranexamic acid was limited but encouraged. So it highlights here that, it is doable. Mortality rates were low and comparable to the general population. And what it tells us is our patients can live longer and hopefully better. So we move now from the major surgeries to what is considered now minor surgery, and that is circumcision, right? Ideally, this should be done as an elective procedure with the Health Hemophilia Treatment Center oversight. It should again be done by people with experience. And it is really crucial when you are going into any of these surgeries to do a pre-op inhibitor screen, right? The factor availability needs to be confirmed, but I think with circumcision, you've now got many devices, and we will be discussing this in more detail at the NASAC meeting. So you've got device choices now, and it is thought that the Plastibell is safer. So I want us to also understand where this fits. Often, you get a rebuttal from the surgeons to say, well, the child's going to come to me at 21 and he's going to say, why did you do my circumcision? But I think we need to think about things calmly. We need to understand the cultural, religious needs, and then we need to make sure that our patients are provided with the right care in safe environments. And crucially, in this domain, it's engagement with the traditional healers. So the protocols, you have a variety. So you have standard dose protocols, and then interestingly, there were some very low dose protocols that have been published. So the standard WFH approach is to maintain 80 to 100% perioperatively, but there were cohorts in Israel and Turkey that were published. The Israeli neonatal series used a single dose of factor together with tranexamic acid. And the Turkish protocol looked at a rapid taper from 90 to 100% to 50 to 60% of cover, right? So things are possible, but they need to be done with supervision and care. And patients should not be denied this. We need to look at the inhibitor status, and we need to see what information we can garner from what's been published. So the WFH cautions in terms of circumcision, bleeding, infection, delayed healing, right? And especially in neonates, if it's done early on, the risk of inhibitor development. Infection risk is definitely heightened when you're doing it in a non-clinical setting, so that's important for South Africa. So just as a reminder, we must balance the constitutional rights, right to health, right to culture. We need to take all of this into account. We need to partner, and this is where organizations like SAHF and MASAC are really important in terms of advocacy. Ensure that the factor support at the time of the ritual is available and integrated time-wise with the flow of what needs to be done. And then educate families to say, we're not saying don't do this. We're saying we're happy to help you. We're going to partner with you to do it in the right way. So when you look at the Israeli and Turkish reports with the lower doses, there were safe outcomes with structured cover. The Senegalese low-dose factor series also showed good results, and bleeding events were actually rare when protocols were followed. So overall, circumcision can be safe with careful planning. So we're going to move now, having discussed largely the approach to patients with non-inhibitors, to inhibitor patients. So generally, non-inhibitor surgery, it's safe, it's more predictable. Inhibitor surgery is, may I say, going into the Wild West of sorts. So it's really, really complex. It's higher risk for bleeding, it's higher costs, and then it means that it's higher stakes. So your options are aPCC or recombinant factor 7, and at some point, patients may even require sequential therapy. Definitely needs to be done in expert centers. So when you look at surgery in patients with high theta inhibitors, what do these high theta inhibitors do? They neutralize factor 8 or factor 9, and this is where the bypassing agents need to come in. If you have patients on emicizumab, generally recombinant 7 is preferred, but there is literature coming through now where your aPCC can actually be used in patients on emicizumab. Hemophilia B with inhibitors, we generally say avoid aPCC because it contains the factor 9 and it can result in an anesthetic result. But you need to look at your context. If you're needing emergency surgery and it's not a patient who's had an allergic sort of response, then perhaps you don't have a choice and you need to do this in a very considered manner. So lab monitoring here can be really tricky because your factor assays are not helpful and you're really looking at a clinical composite. So you're looking ideally at things like TIG, ROTEM, you're looking at your hemoglobin parameters, but really we need to do this in a very planned way before we do any sort of elective surgery. So when I look across the country, what I see is units, some of them have access to both, and then traditionally, for whatever reason, some units have actually only had access to one or the other. And this is not ideal. So we know that in terms of bypassing agents, not every patient will respond to the same agent. So there's a 60 to 70% chance that you will respond to one and not necessarily to the other. So it's really important to sit with the patient's file, look at the prior responses, and understand what's needed for the surgery you're about to embark on. Some of the challenges with recombinant factor is that it has a very short half-life. So it has to be given very frequently, ideally every 2 to 3 hours. And now it can be given as a continuous infusion, but that will require things like an infusion pump. aPCC, generally, we would look at using it 8 to 12 hourly. So it's a little bit easier in terms of nursing administration as well. But there is a maximum here of 200 units per kg per day. Again, there is no point. We as hematologists understand this, that factor assays are invalid. But so often you find that the anesthetists or the surgeons are asking for factor assays in these patients, and that's a waste of time, right? At the same time, when you're using these products, you do have the risk for thrombosis, okay? You add that into patients with other comorbidities, you look at whether they're having a knee replacement, and then your thrombosis risk goes up. So you need to balance all of this together. There may be a point where your patient is not responding. Okay, so it's had a few doses of either agent and the bleeding continues. So it might be something that is local. That is a discussion with the surgeon. But at that point, it's often very difficult to take this patient back to theater immediately because this is now an unstable patient. So in this scenario, we often would switch agents. The literature says we consider plasmapheresis. I'm not sure if any units have actually done this in the country, but most units would probably consider switching from one to the other. An important note, in patients on emicizumab, we want to avoid the high-dose aPCC. So whereas for a non-ME patient, we go up to 200 units per kg per day, for an ME patient, you need to cut off at 100 units per kg per day. Remember, emicizumab's got a very long half-life. And if you add that, that's not being excreted all the time, and you add aPCC on top of that, you are going to end up with problems if you're dosing very, very high. You need to leave very clear instructions, okay, or a plan for what you need to do if the bleeding gets worse. What are your escalation triggers? What's your next steps? So just a little bit more about aPCC and how it actually works. So this is an activated prothrombin complex concentrate. It means it contains already activated vitamin K dependent clotting factors, factors 2, 7A, 9, and 10. And what it does is it generates a thrombin burst, which is independent of the traditional factor 8, factor 9 pathway. So look at the name for it. It bypasses the inhibitor blockade at the intrinsic tenase complex. So the thing with aPCC is it has a fairly rapid onset of hemostatic effect post-infusion, but your clinical endpoint, because you can't measure these levels at all, your clinical endpoint is the patient himself. Is he bleeding? Is the output less? Is the blood pressure and tachycardia more stable? So we've highlighted, and this comes up over and over again, is that the thrombosis risk is increased with high doses or prolonged exposure. You really need to be very careful with two drugs. One is when you're giving it with high dose tranexamic acid, and the other is when you're giving it with emicizumab. So then you need to have a low index of suspicion. You need to be on the lookout. Is your patient possibly having an MI, a stroke, a DVT? These are the ghastly things that can happen, right? If you're considering sequential use of drugs, then you need to actually allow for a 6-hour washout period from the aPCC. So just a little bit on recombinant 7. So this is a tissue factor dependent pathway. It binds the tissue factor at injury, and from there it activates factor 10. And it's a little bit different in terms of its pharmacodynamics. So this gives you a rapid thrombin burst, even in the absence of any factor, and therefore this needs to be given on the table. It can't be given in the ward and then 1 hour later the patient gets to theater and then we incise. That's a no-go. This literally has to be pushed in and then you cut, right? Problem is, and I'm reiterating, that it has a short half-life and you need frequent dosing or continuous infusion. So South Africans have always tried to adapt, and we have looked at a variety of options. So we've looked at using the standard bolus, stretching it out a little bit, and this is because we are constrained, right? So if you know it's a once-off in-out process, then you can give a high-dose bolus. The risk of not having ongoing bleeding, depending on the site, is minimal. That will work in that scenario. But in other scenarios, if you're doing a knee replacement, for example, then you're looking at, can you do a continuous infusion? So how do you choose? And this is a very complicated question, right? But there are some things where we know the site of surgery, mucosal ENT bleeding, generally it's been suggested looking at recombinant, but if you have a diffuse bleed, then to look at aPCC. The next is when you go into your incision and into the surgery itself, what sort of bleed kinetics are you needing or expecting? If you need rapid control, then you look at recombinant. If you need sustained cover, then you look at aPCC. But what's really important is how has this patient, if he's been given either of these agents, responded to these agents previously. It's also important that your center is familiar and you know what's in your pharmacy stores at that point in time. So we also often have to look at costs, and it varies depending on which province you're in terms of what's available. So this decision is often very simply a pragmatic decision based on what you have. So just in terms of surgery in patients on emicizumab, Emi is not something that's going to give you better prophylaxis when your patient is going to surgery and you top him up. It does not work like that. It does not work in the same way as factor. What it gives you is a steady state, so it provides baseline prophylaxis, but it does not give you acute bleed therapy. So depending on the type of surgery that needs to be done, you may still require factor or bypassing agents. And traditionally, the recommendation has been recombinant, but increasingly now there is more information coming through that we could be using aPCC with strict dose limits. Importantly here, when you're looking at your assays, you need to use bovine chromogenic, and this is not done in all the labs. So it's something where if you have a patient with ME, that MDT planning actually needs to be even more tight and detailed. So the Stacy registry looked at outcomes of patients on EMI perioperatively. They looked at about 200 surgeries. The majority of these were managed with a recombinant, but interestingly, and this has been presented by Prof. Mshlangu locally as well, minor procedures were often only covered with EMI and tranexamic acid, and they managed very well without bleeding. So again, we need to start documenting our own outcomes with all of this. So when it comes to bypassing agents, if you're doing minor procedures, preoperatively, you're going to probably use 90 or 270 of the recombinant. If it's aPCC, depending on the type of surgery, either 50 to 100 at the first dose. And then you're going to redose for recombinant every 2 to 3 hours, for aPCC 8 to 12 hourly. Again, local measures, fibrin glue, topical tranexamic acid, and pressure dressings would be important. And remember, we said minor meant 1 to 3 days of coverage, and examples of that would be dental extraction, but anything more than 3 teeth is actually considered major. A port insertion is considered minor. A biopsy, depending on where it is considered minor. But always have backup in case things go wrong. So for major surgery, your starting doses are pretty much the same. These patients need to be in ICU. If you have breakthrough bleeding, think about switching your agents. And then look at tapering. And the question often is, how do I taper? When do I stop? When do I start to decrease the factor that the patient is on? So generally the tapering is done sort of with dosing intervals after 3 to 5 days. If they're stable, then you could probably decrease by 20% or 10%, depending on the composite picture. So we did have a presentation, I think it was last year or the year before, on the possibilities of robotics in hemophilia as well. The benefits, and it depends on who you speak to. So the benefits are that it improves alignment precision compared to conventional surgery. Your implants are better positioned, and this is giving you potential long-term survival gains. The challenges are, however, that it requires longer theater time and there's definitely higher costs. So what we want here is we want partnership. We need these kinds of surgeries for complex patients, like patients with hemophilia, and especially patients with inhibitors in hemophilia. These are the kind of surgeries that need to be done in centers that have higher volumes and therefore develop expertise. So it is useful technology, but your hemostasis is still a limiting factor, and we need to get that right. So with all of these surgeries, we have to think about thromboprophylaxis. And generally, although we think about hemophiliacs as bleeders, the good thing is that their baseline venous thrombosis risk is actually lower as a result compared to the general population. However, that does not mean that in orthopedic and abdominal surgery, there's no risk. It still carries a risk. And then you need to look at what adds to the risk. So obesity, immobility, previous thrombosis, malignancy, or cardiovascular risk, right? So your first line is mechanical prophylaxis, so compression stockings, mobilization, and then you're going to use pharmacological prophylaxis very seldom, but only where you have strong added risk. And you need to balance this clot versus bleed risk. So the priority really is to get these patients up and going and to make sure that their risk of rebleeding is very low when you're doing this. So good coverage in terms of product is really important. So I want to just look very quickly at lab monitoring, what to measure and when to measure it. If you have a patient without inhibitors, this becomes more simple. You want to make sure that there's no error in the type of patient that you're dealing with. So you want to see a documented proper lab result, not a what if. You should always screen all patients prior to surgery for inhibitors. And when would you repeat this inhibitor screen post-surgery? So say your patient's been negative, but the bleeding is unexpected. So it might be a problem with the site, but you absolutely have to exclude that this patient may have developed inhibitors. So thrombin generation assays, I think perhaps because they live out there in the theaters and we don't get to play with them that much, we're not necessarily very comfortable with them. Largely, they've been seen as a research tool and not routine. But I think given the logistics in South Africa, this is something where we need to pay more attention. So we need to try and gather and understand this utility better for our patients. And then it goes without saying that you do the regular fibrinogen, platelets, and hemoglobin alongside your factor covers. So this is a Rotem and a TEG cartoon. And what it does is it looks at how your clot is initiated. It can tell you about the kinetics of the clot and the strength of the clot as well. It's very useful in trauma and cardiac surgery, but the problem is that it's got limited validation in patients with hemophilia. We do know that the Rotem profiles are abnormal in untreated severe hemophilia A and B, but the issue is that the correlation with your bleeding phenotype is weak. So it may overestimate your hemostatic safety after partial correction. Bottom line, it's a tool that assists, it's not a tool that replaces. All right, so that's important. So I'm going to end on this article, which I think is an important one just to read and share. And this was by Cedric Hermans, who also, I think, presented to us about 2 years ago. And this was looking at invasive procedures in patients with hemophilia, a review of low-dose protocols, as well as experience with extended half-life factor 8 and 9 concentrates. So understand that hemophilia treatment for much of low-income countries is facilitated by a donations program from WFH, which is where countries like Senegal, for example, might end up with an extended half-life concentrate, or sometimes even things like fitusiran, right? So this looked at, we know the WFH protocols would usually suggest for major surgery, 80 to 100%, and then you taper to 30 to 50% over 7 to 14 days. So that's a lot of factor that we need to have. And WFH actually acknowledged when they looked at all of this and the studies and the series that were published, that looking at reduced troughs may be well feasible in low and middle income countries. So India published a series of patients, of 37 patients, including orthopedic, cardiac, and neurosurgery, and they used levels which were really quite low. It's important to unpack, and that's done in the article, in terms of exactly what type of surgery that was done. So they used levels going down as low as 20 to 40% for factor 8, 15 to 30% with successful hemostasis and no major complications. Overall, take home, this was possible using 30% less factor compared to the WFH dosing. So again, I'm going to urge you to look through this article, but just to highlight a few things. For example, an angioplasty in 9 hemophilia A patients using a single dose of factor at 25 IUs per kg. Senegal, in terms of their circumcision series, 26 boys, again, using a very low dose. We don't know the exact weights, and these are the things that we need to actually start to look at for ourselves. So the other question for when you have very little factor is it better to give it as a continuous infusion or leave it as a bolus? So the good thing about continuous infusions is that it provides steady state factor levels. And as a result, you get a 30% deduction in how much of factor you're using. So you have stable intra-op hemostasis, you have fewer breakthroughs. Ideally, what you're getting out of all of this is a predictable PK, getting smooth coverage. But the reality is aging infrastructure, no equipment. So if you have the pumps and if you have the staff to monitor this works well. This can change things. For now, many people use bolus dosing because it's widely feasible, it's doable, but it's something that we need to think about. These kinds of surgeries should be done in a high care ICU setup, and this is where we can actually get away with using even less product. So I'm going to end here in terms of what not to do in hemophilia surgery. You definitely cannot wing it, right? You cannot act alone. Put your team caps on. Come together and discuss it as a team. Share experiences. Share experiences across. So orthopedics and anesthetics, bring everybody to the table. Don't wing it. You need to have a clear written plan and make sure your drugs are available. Definitely avoid any empiric dosing without doing an inhibitor screen, especially for major surgery. And then avoid the tendency to sort of do unmonitored sequential use of drugs as well. Always, always combine drugs. But when you do that, when you are thinking of it, think about the thrombosis risk, right? And then be mindful in terms of what analgesia the patient is receiving. So when we think about surgery, we usually ask about things like how many operations have been done by each unit, how many extractions have been done. But I think what we are looking at now is an understanding is we need to understand clear definitions, and then we need to have the same kind of standardized surgical data forms across the country. This is the only way we will be able to look at what's happening, what's the dosing, and the outcomes. And we can actually build this evidence base drawing from countries like Senegal and India in terms of looking at lower doses for surgery. So your take-home algorithms and checklists, if you're looking at surgery in hemophilia, plan early, discuss your cases, see the patient in a pre-op clinic as an MDT at least 6 weeks before. Understand what your target levels are and how much product your patient is going to need. This country, you don't have choice about factor, but you do have choice with bypassing. So select your agents carefully and then build your perioperative plan. Look at the dose, look at the monitoring, and know what you're going to do if you're going to escalate. PBM, patient blood management, really important. So I'm going to stop there and thank you all. And let's see if we have any questions.
Thank you so much, Yasmin. I think that was a very, very in-depth and a very nice summary of what we need to do. So, yes, we're open to questions. I'm not sure, Jacques. I see you've posted one or two things in the chat. I don't know if you want to ask them. Dr. Malherbe?
Hi, so I'm just driving at the moment. Yeah, I was just wondering about the tranexamic acid. I was always taught that it's contraindicated if somebody's got hematuria due to the proposed risk of ureteric clots and obstruction. But I see it's clearly recommended in the urological guidelines in surgery in patients with hemophilia. So yeah, I was just wondering on how strong the contraindication truly is to use tranexamic acid when there's hematuria present. Yeah, and then I just made a comment that I'm not sure if you also find the same, that especially in adults, using during surgery, generally aPCC works out cheaper just due to the dosing schedule and the duration of cover that's required. But when you use it for short periods like a bleed, recombinant factor 7 is often cheaper. But yeah, I'm not sure if that still holds true.
Yeah, Jacques, perhaps I can answer that. So I think in the last tender, there were significant pricing changes that came through. And right now, your aPCC is actually considerably cheaper. It's also, I think, much easier when you look at how constrained we are, especially in the state sector, with nurses and coverage even in ICUs. It's just you need to be sure that your patient is receiving the product. So if you have somebody on a 3-hourly dosing regimen and they miss one of those, it can be catastrophic. So it's actually quite a considered decision that one has to make. I think my one caution would be when you have a hemophilia B with inhibitors and you have a history of allergic type reactions, then you need to consider a recombinant. But by and large, I think your aPCC definitely works out cheaper. If it's my practice has generally been, if it's an in-out quick surgery, then yes, I'd consider the recombinant. But where I know I'm going to be stuck in for days, then I have to look at what's more logistically feasible for me.
And then Sister Annie has alerted me that Prof. Mahlangu actually has got his hand up. Oh, I see up there. So Prof. Mahlangu, the floor is yours.
Thanks, Jan. Thanks, Yasmin. Very, very nice, comprehensive overview. I've got a comment and maybe a question to ask. And the comment is perhaps for the benefit of the registrars in this call. We've recently done a review with regard to the use of an aPCC in the context of non-factor therapy. No, to our surprise, this was published recently in the RPTH, and to our surprise, in fact, despite the black box warning and all of that, the usage was actually very high. And it speaks to the point that you alluded to, Yasmin, that these products are actually complementary, and the response may be variable not just between patients but within the same patients. You could use one product once and it works, and you try the same product another instance and it doesn't work. Just to give you some of the figures from that publication, and it's all online, you can actually get it for free. If one looks specifically at the clinical trial, the Haven programs, 81% of the patients who had breakthrough bleeds use an aPCC without any thrombotic microangiopathy. And if one looks at the proportion of patients that use less than 100 units per kg, it was 76% in the context of breakthrough bleeds. It's only in the setting where the usage was above 100 units per kg that there were 3 thrombotic angiopathy and thrombosis associated with that usage. Essentially, talking to what we already know, that one shouldn't be using an aPCC for breakthrough bleeds in excess of 100 units in any given 24 hours. Perhaps that was the comment I wanted to make. And that paper is now, I think, fully available. It was published just before ISTH in June. The second comment I wanted to make was regarding whether it is cheaper or not to use one bypassing agent versus another. I think all of us sometimes fall into the trap that cheap amounts to convenience and vice versa. I have not seen any data that shows that one is cheaper than the other. The only data that I have seen is the benchmarking of how the cost is calculated. And if one goes according to the cost per unit, they are exactly the same. It might be convenient not to give it every 3 hours, but give it every 8 to 12 hours. But the cost per unit remains exactly the same. And that is the data that most of us here, in fact, have seen repeatedly being flaunted around by various role players. My question relates to the role of the global assays in monitoring these patients in the peri-surgical setting. What's your take on that? And does it have any utility? And I must admit here that I'm a little bit at a loss because various individuals have got different experiences. Thanks again, Yasmin, for this very nice, comprehensive overview.
Hi, thanks, Prof. I think, yes, the use of the ROTEM and the TIG, it's still very unclear. And I don't think we as clinicians actually have enough baseline experience, never mind within patients in this group. So from the reading so far, what it seems like is it's particularly useful in the intraoperative timing to look at real-time hemostasis in theater, but I didn't find very much about it in the post-operative period. So that's where we are. And it might make for an interesting study, depending on when we do it in centers that have higher surgical volumes. So I think some of the things that we still need to give some thought to, and we need to look at which are our smaller projects that we can start off on, which have more impact at this point, is to actually, and this is one of the things that the guidelines committee will be looking at, is the issue of circumcision. And we hope to be doing sort of consensus statement or a guidance in terms of circumcision in South Africa, taking into account which is the right timing and all of those things. So that's a project for next year, I think, for MASAC. Yeah. But that's me speaking with my pediatric hat on, generally. Just wondering if there are any other questions.
Yasmin, whilst people are still putting in their thinking hat on, can I comment on the low dose?
Yes, Bob, go ahead.
When the third edition of the WFH guideline was being put together, there was actually quite a robust debate as to whether it should be recommended or not recommended for use in hemophilia. And I think the general consensus for most of us who were involved was the notion that we were trying to introduce prophylaxis as the standard of care. And therefore, if you had limited access to these therapeutic agents, you could start with low dose. But we're quite clear in our mind, and this was backed up by tons and tons of data, that if you give homeopathic doses of any hemostatic agent, all you are doing is wasting, and in fact, you might even do more harm than good. But we're comforted by the fact that those who started, at least they could start to practice prophylaxis. When they do at some stage have access to appropriate doses that we know do work, at least they would have practiced on how to administer prophylaxis. So that is the context in which, and again, this is for the benefit of the registrars, that low dose is not actually recommended as in it is effective. It is recommended because it is a good starting point to introduce prophylaxis. Some of us, in fact, were quite very much oppose to the introduction of low-dose prophylaxis for that reason, that one would rapidly see joint deterioration without any benefit to the system and to the patients.
Okay. Prof, thanks for that. So I think, I'm just curious whether people have any thoughts in terms of how you increase access to things like TK, total knee replacements, because there's always pushback from many centers and a great reluctance to take this on. I know Joburg Jen has been doing many, or rather Charlotte Maqeke, but there's a need for a different approach at both national level primarily, where rare diseases requiring this kind of intervention actually has a ring-fenced budget and 2 or 3 centers where this is actually possible. Okay. Yeah, and I don't see any more comments in the chat. I'm not sure if
I don't see any
no.
either. I don't see any hands that was raised, and I think we've reached the end of time.
Yeah.
With that, I am going to thank you so much. As well, Yasmin, you really covered this really nicely. I think answered a lot of questions and the questions that people did have. At least there's a roadmap how to get to the answers. So very well done, and thank you so much to everybody for listening. And with that, I am gonna say to you, have a lovely Monday evening. Thank you, everybody.
Thank you, Jan, for chairing, and have a great afternoon, everybody. Goodbye.